Welcome to HIMSS Indiana Chapter's continuing webinar series, focusing on AI, cybersecurity, and public health. Today's webinar is the first in our public health series. During today's discussion, our panel will explore the promises, barriers, and best practices for implementing digital solutions to achieve health equity. Thank you for joining us. I'm Rob Gottlieb, Indiana HIMSS Chapter President. Today's program has been created to address the needs of healthcare organizations and IT professionals in our state. While our chapter leverages the assets of HIMSS, a global organization with over 125,000 individuals and 1,000 provider organizations, nonprofits, and health service organizations, our chapter is laser focused on local issues. Our purpose is to help Indiana organizations transform healthcare and to empower Indiana healthcare IT professionals. Our chapter's membership is 1,000 strong. The following provider organizations are HIMSS organizational affiliates that support local and national HIMSS initiatives. If you're employed by one of these organizations, you can become a chapter member at no cost. Visit our website to register. Based on discussions with our members, our programs this year focused on AI, cybersecurity, and public health. As a nonprofit, we're reliant on sponsorship fundings. Thanks to our chapter sponsor, Nutanix, for making today's content possible. Special thanks to our board and program members who give of themselves to support the mission. If you would like to explore taking an active role in the chapter, please reach out to me or one of the other board members. I would like to introduce our moderator for today's session. Our moderator cut his teeth in healthcare at the age of 16 as a medical clinic janitor, serving as a combat medic and rising to a C-suite position of some of America's most respected organizations. He is a writer, podcaster, and trusted consultant in the healthcare digital transformation space. He is dynamic, as is technically well-versed. Get ready for a fast-paced discussion. I'm pleased to turn the program over to Ed Marks. Ed?
Hey, Rob, thank you so much for that introduction. I'm super excited about today's webinar. So, of course, we have a housekeeping slide. It wouldn't be a webinar without one, but I think everyone's probably pretty adept to how this works. So you can see 1, 2, 3, 4, and be sure to take note of that. You'll get a copy of any slides that we have. And so you'll know that you can, I'll just highlight one thing, submit questions. So we want this to be interactive as much as possible. So please, we'll be monitoring the chat. And the way we'll do it is we won't wait till the end. So if there's a fresh question that comes up based on the current conversation, we'll do our best to get at those questions right away. So we're happy to modify the way we flow based on your interactions. So that's really it. And you see the feedback and all that kind of stuff and how to get CVs. So with that, let's go ahead and bring on our panelists. So today's objectives, as we get there, you can read it. I won't read slides to you. Like I said, we'll make sure you get a copy of all this. But the goal really is to be super interactive. And what makes this most exciting, as you'll see, and the panelists will introduce themselves here in a second, is that it's just not from a tech leader perspective, which is always great to have, but it's a great mix, both from a digital health perspective and to clinicians. So that's what's going to make this super fun. So with that, I want to introduce our panelists, and we'll just start as you see it on the screen. So Dr. Desi, we'll start with you. So what we want to do is hear one thing interesting about your organization, and then one thing most people attending the webinar would not know about you. So something unique.
Sure thing. Thanks, Ed. My name is Bimal Desai. I'm the Chief Health Informatics Officer at Children's Hospital of Philadelphia. I've been here for about 24 years. One thing that people may not know is that it's the first and oldest hospital in the United States dedicated to the healthcare of children. One thing you may not know about me is I actually have an Indiana connection. When my family first immigrated from India to the United States, We actually settled just outside of Terre Haute, Indiana when I was a toddler. And by all reports, my parents tell me that's where I learned English, at St. Mary of the Woods Montessori School. So I owe a lot to your state.
All right, that's cool. And I didn't realize that about CHOP. So this is great. So Dr. Bhandari, we'll go to you next.
Hello, my name is Anuradha Bhandari. I am an internist by training and a physician here at Reed Health. Reed Health is located in Richmond, Indiana. It serves the eastern Indiana and western Ohio area. And we're about a 271 bed hospital. Richmond actually is the home of recorded jazz. So that's a fun fact about Richmond, Indiana. One fun fact about me, there was lots, but one thing is I am of Fijian descent. So originally born and brought up in Toronto and then moved to the States. Didn't think I'd live in rural Indiana. Been here for about a decade now, and it's been a pleasure. Thank you for having me.
Awesome. Super interesting. And Muhammad, how about yourself? One
Oh,
thing
thank-
interesting. Yes, go
Thank
for it.
you. Thank you. This is Muhammad Siddiqui. I am not going to repeat what Dr. Bhandari and I belong to an amazing organization, Reed Health. I'm a Chief Information Officer here at Richmond, Indiana, serving 35,000 plus community member in Richmond. We are a rural health system. One thing unique about me, I have had a privilege to work overseas, work at Cleveland Clinic Abu Dhabi and work very closely with Ed Marks there as well, and also in Saudi as well. So I have some expert experience working in digital world and healthcare as well.
Yeah, so not only great organizations that you all come from, but a great background for each of you. So let's jump in, and not all questions will go to all the panelists, but the first few for sure, somewhat of a setup. And so what we want to know, and Muhammad, we'll start with you and just work our opposite way. What's your organization's approach to community collaboration, since that's what we're talking about here today?
Oh, thank you. That's a great question to segue our conversation today. So Reed Health believes in a power of collaboration. How can we work together to drive meaningful change? We actively engage with our community leaders, schools, and we have a couple campuses, Ivy Tech Community College. We have IU Health here as well. So we work very side by side with them and say, listen, how can we leverage each other experience and each other resources to help out, right? So collaboration is kind of built in our DNA. We actively seek partnership with outside the state as well and see how we can help each other out. And definitely, we don't want to duplicate the efforts because we don't want to work on something that's already been done and don't want to reinvent the wheel. So that's our digital approaches.
I love it. And before we head to Dr. Bhandari to get the clinical perspective at Reed, I want to also introduce Max. So Max, tell us something interesting about your organization and something unique about you.
Thanks, Ed. Good afternoon, everyone. So Parkview just recently, last year, I think was one of Newsweek's only Hoosier workplaces in the most loved places to work, which is pretty unique for a healthcare system. So great culture, great people up here in northeastern Indiana. So I guess one thing unique about me in particular, I was in a building hit by a tornado in Atlanta. I've been in an earthquake in Los Angeles and a small tsunami when I was visiting Hawaii. So I'm probably not your best travel partner, Ed, but thanks for the intro.
All right, so we'll hope for a steady webinar here. That's pretty. That's also pretty interesting. So, Max, we're going to stick with you. Actually, how does your organization approach community collaboration?
I think Parkview does this typically with focusing on promotion and education within the community. Probably accessibility is close behind that, but I think trying to get out there to partner with groups, whether that's that could just be as simple as creating structures within the community that allows for hosting things like ball fields, sports training, events like that, that allows for pathways to get health education out there and other promotion of wellness out in the community. We focus a lot as well on vulnerable populations that might, based on our zip code representation, food deserts, those types of things, looking to help how we can access additional information and care to patients in those areas.
Yeah, those are super examples. So back to Dr. Bhandari. So from your perspective, what is Reed Health's approach to community collaboration?
So I'll just say something a little bit different or different approach. The culture is of a service attitude. It's a small group, community. Richmond in itself, although we serve other areas, about 35K people. So I say, how do we understand what the community's needs are or collaborate? We are the community. I think we're the largest employer. And so our needs were very much we understand very well what the needs are within the community because we're living there. A lot of us are raising our children and have our families here. So I think that that's a huge asset, not so large, but close enough, 2 degrees of separation really. And then that allows us to really, I think, communicate with the community and understanding what the needs are. I think we take our community health needs assessment where we have a data-driven approach, which I think is a critical way into showing measurable change. So I think those are some of the things that we work with externally, and then internally, again, with, like Mohammed mentioned, lots of collaboration internally to understand the needs of the community.
Okay, super. And Dr. Didal, how about yourself? How do you approach and your organization approach community collaboration?
Yeah, so we're very fortunate. We have a pretty robust Office of Government and Community Affairs. It's led by Peter Grohlman at our institution. And we have explicit branches of that work with our city leadership. So for example, the City of Philadelphia Department of Health or the City of Philadelphia, the Mayor's Office and things like that. And what's really nice is that oftentimes we'll choose these partnerships around specific themes. So for example, asthma care, where CHOP has a partnership with the city to actually identify children who are at risk for readmissions and high acuity visits based on their history with asthma. And we will actually not only take care of them in the hospital, but then connect with them out in the community, remediate their homes in some cases to get rid of like mold and other kinds of triggers for the child's asthma, and really make an impact in their lives. The other example of this is that we have a Center for Health Equity within the Children's Hospital that runs, for example, this entire community asthma program through Dr. Tyra Bryan-Stevens. And so what we look for are opportunities across the board where we can really influence the health of children, whether it's technology related or whether it's something else like the built environment that they live in.
Yeah, so we started off just talking about generally how our communities engage, how we engage with our communities in our health systems. But we know that digital literacy can be a challenge, whether you're a big city or rural healthcare. So super interested, because I think you all are giving such great practical answers that our listeners can grab onto, hold onto, and replicate in their particular organizations. But something, again, we all struggle with is this whole concept of digital literacy. So curious how your organization tackles it. And you just spoke about having a dual approach. Is there anything else that you'd want to share from a CHOP perspective, how you handle digital literacy? And like I said, it's great because you realize not everyone is going to be, digitally enabled. So you have to use traditional methods, but also some new methods. If you could share a little bit what you're doing in terms of digital literacy, that'd be awesome.
For sure. So within that Center for Health Equity, I've actually, I work very closely with a pediatric informaticist named Dr. Sunsini Craig, who is working to establish a digital health equity roadmap. And one of the things that we're discussing now is what are the major themes that we want to tackle as an organization. So clearly, digital access is front and center, right? Can our patients and families even access the technologies that they need? So for example, our MyChart, which we branded as MyChop at our institution, patient portal, can they access our telehealth tools and things like that? The second one, which is, I don't think it's unique to Philadelphia, but we have a lot of non-English speaking families in this region and Philadelphia is sort of like a city of neighborhoods. So we have families from Southeast Asia, we've got families from Eastern Europe and families from West Africa. And so language concordant care is another big theme for us that we need to figure out. Are all of our platforms accessible and available in multiple languages? And then the third one that I would mention is we are trying to wrap our minds around what are the digital health tools that we need to support social determinants of health. Some of you maybe have heard me say this, but Philadelphia is often described as one of the largest poor cities in America. Something like 30 to 40% of children live below the poverty line in Philadelphia. And we really are trying to understand what are the impacts of poverty and low income on health status, and what can we do to surface those and then respond to them appropriately.
No, those three are some great tactics and strategies that you're leveraging. Max, what about at Parkview? What sort of things are you doing to tackle digital literacy?
Yeah, those were some great examples. So I don't want to repeat any of those. I think maybe to give specifics on telehealth platforms, Dr. Desai mentioned the MyChart platform. We use that and other additional apps to really focus on how to enhance engagement with patients. So how do we further the reach of care and eliminate some of those geographic barriers or additional barriers that might exist? And we're doing that with apps and with these platforms that really haven't been available before. That can also help us kind of transition from episodic care to a care journey with patients and really help deliver on those care plans in more of a coordinated fashion. So those are helping in a big way with communication. The other two pieces probably I'd add are data. So I know in the world of AI, everyone's buzzing around data. We as health systems have a lot of that. It's just an ability to now take that data and make it incredibly personalized to these patients so that you can address all of those gaps that exist, which are going to be vastly different for each individual patient. And doing some of that with our online platforms, which are slightly different than our telehealth or mobile apps, helps to engage the audience, to provide information when people may be able to digest it and in ways that they can digest it.
Super. Dr. Bhandari, what about at Reed Health? Same question.
I think we forced the mindset of the community, and I think in some ways, bridging that gap and tackling that was first understanding some of the infrastructure issues within Indiana. So Indiana just recently in January released a study of a digital sort of plan, a 5-year plan, and they looked at the data in the communities that were struggling, which areas had high gaps within their digital literacy. And that allows us to kind of focus at those communities and look at what those gaps are. And that's from an external standpoint. If you drill down internally within the organization, I think pushing the mindset of patients, and I would say that COVID was and I'm sure we've heard all about this, right? That COVID was the opportunity that pushed folks to start thinking about this. We removed so many barriers nationally, statewide, and even within the community. So I'll go practically. I'll go right down into the patient and the doctor relationship. And what is really important is changing mindset and building trust. So what's really interesting is that we've been working internally at getting the physicians and the clinical staff to structure healthcare in such a way that it incentivizes the patients to make that mental stretch and start doing those things with respect to becoming more digitally literate. And so I'll do very simple things in the office where I ask them, are you on MyChart? Are you registered yet? And they'll say, well, no. I say, oh, I'm so sorry about that. Well, I guess that means you're going to have to wait for the nurse to come in to print out your appointment thing. If you had it, you would have been able to walk right out and I would have sent everything to you. You could schedule your appointment whenever you want. You can see my schedule. And suddenly you've opened up the eyes and the world to the patient, and they realize that actually they're at a disadvantage when they don't do this. And so then the patient feels a little overwhelmed about, okay, so what? So we tap them into resources to get them educated on how to use these things. And once you can get a patient's foot into that water, then the whole world opens up, because now you can do digital-based education, communication. You've removed barriers towards access to treatment and medications and communication two-way without burdening the process for the patient with waiting for phone calls and all of that. Things are much more faster. They come back and they tell you, this is amazing. What more can I do? And so I think that the pandemic removed the barriers because we all said, oh, it's not going to be possible. Telemed's not going to be possible. All of these digital things are not going to be possible. And then the need happened. And although, yes, it revealed some disparities, it also pushed the mindset of the patients. And the reason why I say that is I know that we think, especially in rural areas, there's patches of infrastructure that are missing. But this study, the digital plan that looked at the current status quo, showed that over 85% of patients respondents rather in this survey group use digital methods for things like banking. So if 85% of people are using digital platforms for their banking, then that doesn't necessarily translate to a literacy issue as much as there is a mindset and a comfort issue. So we've got to do what the banking industry or the education industry is doing in healthcare, even in the rural community, because folks are using it. It's just you have to build that trust. And I think that happens when the doctor and the patient are in the room and they look at the face of the person that they trust with their life, and they can push their mindset to try and adopt these things.
Yeah, that's a very good point. Thanks for bringing that out. And I love the whole concept of building trust. So critical to anything that we do. So Mohammed, I'm going to pivot on this question a little bit and look for one other panelist after you answer this question that might give additional insight. So one of the panelists just signal to me how you feel about this question and add to what Mohammed's answers. So what are some examples? So Dr. Bhandari actually gave us one or two already, but how, tech and digital support and accelerate this collaboration while closing the literacy gaps. So in practical terms, are there some things that you've done at Reed Health that help with that?
Yeah, good question. And I don't want to repeat some of the things Dr. Bhandari has mentioned, but technology serve as a powerful tool for collaboration and education as well, right? So Reed partner with our community college, and we have a nursing program where during the nursing education in our community program, they have access to our electronic medical record education platform. They have pretty much access to most of the tools that are available for our nursing. So we want to make sure we also need to look at it and see where are the skill gaps going to be in the future. I mean, digital is become such a powerful currency in the future. I mean, we all see what's happening with the Bitcoin out there. Dr. Bhandari gave you a lot of examples about the MyChart. The other thing that we are working very closely at this part is we're going to be creating a tech bar or tech desk in our main hospital. So when our seniors walking into the hospital, the first thing they can see the tech bar or tech desk. And this tech desk will be equipped with the remote patient monitoring devices with variety or different applications to help assist our senior how to use that. I mean, how to log into the MyChart and that kind of stuff. So I think these are a couple of things that we're doing other than telemedicine. I think we all have it in the place, but I think telemedicine makes a huge difference in a rural health communities. Think about this. You have a mom who's looking for child specialist, which is an hour drive. You don't have to drive anymore. And this is all the reasoning for the technology. So I think I will just close this. I mean, this is there. We all have to work together, and we all have to work together on this.
Yeah, one or two other examples from any of our other panelists on how you're doing this. Those are good, Mohammed.
Well, and I want to echo Mohammed's comments about sort of the driving distance. I think it's fascinating to think about distance itself as a form of disparity, especially for remote communities where, I think it's been clearly shown in the adult literature, for example, that how far away you live from a center of excellence for cancer care determines your outcomes, which is kind of a terrifying thing, right, to think about, that literally how far you are from your health system can make or break your cancer outcomes. And so for us, I absolutely think of telehealth as a way to bridge that disparity. It's also a way to bridge other kinds of disparities, like, if you have families, in our case, we have children who need to be pulled out of school for a clinical encounter, or families who have to leave work to bring their school to those encounters. And both of those are stressful. And, if you have tenuous employment, you might lose your job because you missed too many days of work So offering these kinds of tools, I think digital can actually bridge disparities in a useful way, whether it's distance or whether it's because of employment or school or whatever the issue is. So it's not all negative, right? I think we can focus on some of the positives of digital interventions too as a way to close some of these gaps.
So
No,
I'll
those
add
are-
a little bit to that, just kind of running off of what Dr. Desai said. And that is, he's talking about children, and I'll talk a little bit about rural Indiana and the senior patient population. And we've used the same thing. You've got, the children of these aging parents who have jobs that or live in other cities, and engaging them to help with by having them as a proxy within the medical record allows them to see. And I've picked up the phone and said, hey, can you take a look at everything that's going on, and let's work together to help facilitate mom or dad's care. And that is having them being able to see exactly what's going on with the patient's experience journey, the things that need to get done. And more often than not, those, you've been able to avoid delay in care because family members are apart and they're sitting where they're sitting, and they don't have to take a day off to drive from, say, Indianapolis to, Richmond, for example, which is an hour and a half to take mom to the doctor. They know that they can trust me to work with them within the medical record and the way that we communicate through my chart. Other things we've done is AI or ambient AI for the notes within the room. I think that really changes the patient's experience with respect to they're not watching me kind of typing away on a computer. And just actually last night I was watching a bunch of Instagram shorts about doctors and the patient's experience, especially the younger crowd, their experience of what it's like to be in the room with the doctor, and the doctor's dictating in front of them and they're typing and they're like, okay, well, I'll give you a nose spray for that. Okay, bye. And they run out of the room. And we don't want that to be the patient's experience. We want to give them what they're looking for, and being able to look at a patient, talk to them. And now I have the time to educate, and that's empowering and making the patient an active participant in their care. It's very passive when you're just staring at a computer and typing and you look like a clerk, really. So I think that using ambient AI has been a huge boon for us to be able to go in and feel not the burnout's gone and the enthusiasm to teach again with patients is back. They feel like an active participant. And then we've also, when we talk about stepping away from, the distance, we've done e-consults, right? So being able to send, and it's asynchronous within the electronic medical record, because we can't maybe get the patient into their neurologist, for example, but we have a question. You can collaborate, and that neurologist is not feeling defeated. They're doing a consult. They're taking their time. It's asynchronous, and they're reviewing the chart and offering the primary care physician the internist information, and that expedited care. And patients are watching all of this conversation happening when they have access. So these are some of the things that we're doing within our organization to kind of promote that adoption.
No, those, again, super great examples. And we want to keep on that path and sort of making this a really practical and informative webinar. So you mentioned user experience. So I want to pivot a little bit to user experience, because some of the questions that we've had previous to starting our panel today were around user experience. And so Max, I'll turn to you, and in the context also of, what is our responsibility as leaders at our healthcare organizations? And so how do you look at patient, the user experience, the patient experience?
Yeah, I think it's so critical. In the medical world, we love having everything documented, give big instructions, step-by-step things. And I don't know that that's what patients are looking for anymore. You buy an iPad now and it doesn't come with a set of instructions that's 500 pages long telling you how to use it. It's just usable. I mean, the joke, I think, is that you can hand it to a 4-year-old and they can figure out how to turn it on and work through it, right? They'll push the buttons. So I think that's our responsibility to make software, we aren't software makers, so to make experiences with our software partners and vendors that are intuitive for people to use. And that is I think a really big responsibility in our medical world, where we typically don't give patients all of that responsibility. We typically walk them through, or we carry the responsibility to schedule an appointment or to do whatever that looks like. So I think choosing our vendors, I know with some of the mentions of MyChart or MyChop, I presume we have the same EMR vendor in those cases. So maybe we don't have as much choice of vendors as perhaps we have influence on those features that get rolled out. And those features are constantly evolving. So there's a lot of feedback loops that we can participate in, get feedback from our patients on what's working. And the neat thing about digital is it's all tracked. I mean, you can see what buttons people are clicking on or where they're leaving a site or an app. And we can give that feedback to our programmers and developers to make those adjustments to improve that experience.
Great. And from a CHOP perspective, how do you look at user experience?
Yeah, it's definitely tricky when you're dealing with children. You know, we have not just the patient's access in mind, but of course their parents and proxies. And then you have the edge cases of things like foster parenthood and things like that, where it makes it a little bit more complicated. I have to confess that this is an area where I think we can and should do more. As Max described, a lot of us are using the vendor supplied portal, and we sort of take them at their word that they've done the testing with patients and end users. But even within that, we have the opportunity to control some of the experience pieces, right? So if you have implemented online scheduling, for example, almost all those design decisions are up to the health system to make, right? How easy or how complicated you want to make that. And I do regret a little bit that we actually probably didn't engage patients and families the way we should have when we designed our online scheduling platform. We almost designed it from the standpoint of, well, what makes it easy for us to schedule these visits, not what makes it easy for patients and families to schedule the visits. And so even like the screening questions and things like that, at one point, we were looking at the number of consents that the family would have to read and tick off before they could actually get to the telehealth visit, for example, in their patient portal. And we were like, what is this madness? How did we come up with this? That we have 4 separate consent forms that someone has to read and look through, and no one's reading or looking through them and just clicking the button. And so it's moments like that that I think remind us that we actually need to engineer these processes from a user-centered design standpoint, right? If you did this from a design thinking mindset, you wouldn't roll anything out if you hadn't first engaged with the users of that system, namely patients, families, providers, schedulers, whoever, and you would come up with, I think, a very different solution. So one of our projects that we hope to launch by the end of this year, in fact, is actually a digital family advisory council. So a group of families who've raised their hand and said that we are willing to be beta testers for whatever you're considering. And hopefully we can launch that and show some good progress, especially towards this specific question around how you improve that user experience.
Yeah, and you also rolled right into another question I wanted to ask all of you, and that is, what are any barriers, maybe one barrier to success? Because we all know we're talking based on great experiences and some great things that our organizations have done, we're super proud of. And like you talked about, you know, it hasn't been all roses, right? The entire time, but you ran into a barrier and you did something about it. So I'd love to hear from others as well. Like, what is one barrier you ran into? And then what did you do to sort of overcome that barrier? So Mohammed, I'm going to go to you with that question.
I think the biggest barrier working in a rural community for us would be the reliable internet connectivity. I think the infrastructure, and that's what Dr. Bandari touched on that as well, where 30% of the people in rural area don't even have access to the internet. And that's really blocking our access to care as well. So as a Reed Health, we are part of Wayne County. Obviously, Reed Health serve around 8 different counties. The Wayne County, where our hospital is, we are part of the task force for the broadband. We influence the decisions on what should be our focusing on. So we have a very robust program that working with the Wayne County as well. And hopefully we will see the number going to improve there as well. I think the other barrier that I see personally, and I'd like to hear from other panels as well, the trust on technology. And I think that's something, MyChart is available there. People are afraid to download the MyChart. So I can give an example. I was walking to our lab the other day, and a gentleman was sitting there and asking, did you have a MyChart installed? He said, I don't, because I don't trust that application. So I think that's another barrier. Adoption, I think that's something we all have to work together on that as well.
So I'll
All right,
add,
well,
Mohammed,
yeah.
I would say to that, And Mohammed knows me well in the sense that I constantly bother him. I will pick up the phone and say, hey, this is not working for my patients, or this is the feedback. And I ask a patient, multiple patient notes a day, how's it going? What's working? What do you like? What do you not like? And I pick up the phone, and Mohammed is fantastic. He is so approachable. I say, I know that our vendor has all of these things. We need to push outside of that and come up with a different solution. I can't pigeonhole because that's all that's available. What can we come up with to work with patients? But I'll challenge the trust. And again, I'll reemphasize building that trust it comes at the level of me as the clinician. I think that there's no better opportunity. The relationship is no more stronger. It's such an intimate relationship between a doctor and a patient where we have the opportunity to build that trust when we're choosing that is the way we're going to communicate with you. So I incentivize it. I say, listen, if you're on my chart, then when the test results come, you get a message from me. You don't get a phone call from the nurses. And you want to hear from your doctor. And they love that there is nobody in between, the relationship between me and them. And again, I'll go back to what the data shows. The data shows if 85% of respondents that were scheduled, that gave the survey, were fine to use it for banking, 85% in rural Indiana, then there is a trust with us getting them to use the same sort of adoption within healthcare that they are having within banking, and actually 75% I think is in education. So people are going and trusting, banking, which is their money, and they're trusting their education. We've got to push their mindset to adopt the healthcare aspect as well. And that I think starts with the way we can choose to communicate with the patient at a very intimate level within the clinics, within the doctor-patient relationship.
Ed, can I add on to the same topic? I mean, nobody wants to come to the hospital to have fun, right? Patients are coming to the hospital because they are suffering. Just imagine that. They pick up the phone, they book an appointment. They have to wait, push to the book an appointment. They finally got the appointment. They have to wait 23 days to see a primary care provider. They drive their car, go to the traffic lights. They come to the parking lot, they cannot find the parking. That's a problem. Luckily, they find the parking after 15 minutes. They walk into the building, don't know where to go. And they're asking around the people, hey, where is this clinic is? They walk into the clinic, guess what? They have to go check in again. Show them the medical insurance card. Here is my copay. Wait again. Nobody giving them enough information. And I think that's where what Max has said, the user experience, the user design is so critical. I think we need to work together to build a person-centered care environment, not only for our doctors and our clinicians, but also for the patients as well.
Ed, can I add one comment? Or
please.
So I actually think that healthcare and system executives, people that work, in roles like Mohammed's and Max, also have a role to play in making sure that digital health equity has a seat at the table. And, for example, we make purchasing decisions all the time, which software platforms we choose. And it should be, in my opinion, part of the standard RFP process. If you're going to prioritize, information security and cost and integration with your vendors, with your EHR platform, why not also say, okay, what do you do for multilingual support, right? Is your platform available in multiple languages to patients? I think we need to articulate and say what those minimum criteria are for vendors when we select them and onboard them too.
So I think Dr. Desai makes a great point here, which is one of my barriers or discussions was going to be around corporate-wise. Sometimes we make decisions only based on financial ROI, right? Or that there's a big push for that. But I think what Dr. Desai is saying is that it's really important to consider all the factors that have an ROI that may not necessarily be dollars to that. There's a lot when it comes to enhancing a patient experience, enhancing our coworkers' experience, that these could provide a great deal of functionality for. And I think it's part of our responsibility to create options for patients. I feel like that is the goal, is not to necessarily always eliminate every gap, but sometimes the gap is just that there's no options for patients to choose from. So does the patient have the power to, I will pick on scheduling again, but does the patient have the power to schedule their own appointment, or do they have to call a call center, or do they have the option to go online, or do you have multiple options to participate in their care, or are we not giving them any options? And I think those are two critical corporate structure things that we have to evaluate.
Great point.
This is all super good. I already have like 2 or 3 pages of notes here myself. I'm just learning so much, super practical. And I want to get into some other practical things like steps people can utilize. And I just want to remind everyone, please ask your questions, throw them in the chat. We've gotten to a couple of them already, and we're happy to take our panel in different directions based on what you're most interested in. So don't hesitate to throw something out there, and we will try to hit it. So Mohammed, I'm just going to put you on the spot really quick because I just want to frame this from a national and then a state level. So to your best ability, and you've been around quite a bit, so that's why I'm just going to pick on you on this one. If we had a model, you know how HIMSS is great about all the different adoption models, which has actually helped spur adoption of technology and digital capabilities in the world. So it's quite fascinating in and of itself. But if we were to just create one right now on a scale of 1 to 10, where do you think we are nationally in this whole topic of, connecting, for public health, connecting and collaborating with our communities? Where on a scale of 1 to 10 do you think we are nationally? And then we're going to talk about Indiana and then move on to more questions.
Yeah, and I think it's going to be very hard to judge that, right, Ed? Because the urban versus rural is completely different scale. I would say probably the urban will probably be 8. Probably be the rural side, I would say probably the scale of 5. If you want to ask me about the Indiana, unfortunately, Indiana tend to lag behind the national average in digital health, to be honest with you, especially the numbers that Dr. Bandari has shared. 24.7% Indiana household does not even have internet access. 31 or 35 plus % of the household in a rural community does not even have an internet. And that's a building block. Without internet, you cannot get the digital, to be honest with you. And that's what some of the things that we are doing at the Read Health as well. How can we overcome that issue or concern for our community and our patient? We just went live, and I'm pretty sure all of us are Epic customer. That's the electronic medical record that we use. We just went live with the 2-way SMS capability where our patient be able to book an appointment through using a 2-way SMS. So we are finding the ways to serve the patient who are less privileged or they don't have access to the means.
All right. Yeah, that's good perspective. So what I want to do now we're coming into sort of that final stage of our time together, unfortunately, and there's still like some really critical questions I want to ask all of you. So we'll do what's sort of called the speed round. So what we'll do is sort of, and it's going to be hard to do, but I know you can do it, 60 seconds or less on these particular questions, because I know you're all doing great things. And so the listeners will pick up on it and it'll help them in their own organization. So what would you say is your organization's one best thing that you do to connect to the community? And maybe you talked about it already, but maybe there's a second best one that you do. So what's the one best thing that you do? Max, we'll start with you.
Well, I'll give 2 very brief ones. I think we do patient family advisory councils very well. So we bring in patients to some discussions. There's always room for improvement there, but I think we do that well. I also think that we centralize our feedback loops, which I think is really important. So we have one number if you need help or assistance. Our technical support teams, that all goes to one person rather than each individual office. And why that's important, I think, is you can make adjustments because you have a collective amount of feedback all in one area there. So rather than just having it disparately through 100 offices somewhere, you kind of have a good idea that you're getting a lot of calls on this one thing. So our tech support does a great job with that.
That's great. And I know at CHOP, you're dealing with a completely different audience. So what is one best thing that you will do there to connect?
Like Max, I'll probably drop in 2 things, but the first is honestly analytics, that if we can't even begin to tackle a problem if we don't first understand it. So if you're looking at an aggregate statistic like patient portal adoption, it might look fantastic. And the minute you start to slice and dice that according to race, ethnicity, preferred language, I guarantee you'll uncover a wealth of information. And I would encourage you to look at some of the categories like social vulnerability index or child opportunity index, which the CDC has standard definitions for these things that can be applied. As far as one best practice that we've implemented, we implemented a digital health navigator program, which has been very effective. So we proactively reach out to families that based on a couple of criteria, whether it's preferred language or other things, are more likely to have trouble when they try to engage with us digitally, whether it's telehealth or something like that. And we connect with those families in advance of their visit to make sure that they know how to do all the stuff they need. Like, okay, have you downloaded the app? Do we need to get an interpreter for this visit? And so on and so on. And we've shown that with that intervention, we can actually decrease the no-show rate dramatically for those visits.
Great example. Dr. Bhandari.
So I think one thing that is successful is we have gone to the end users within the system. So it's very easy to offer feedback on what's required for better patient care and what the patients are expressing as their needs. So clinicians are able to go to the administrative and digital think tanks within the organization and see meaningful change through the way that we express. So when we spoke about approving vendors and approving additions to our electronic medical record or how we communicate out to the community, all of that runs through a lot of our physician and clinician-based feedback mechanisms. We have governance that allows us to give feedback on what will work and what will not work, because there's nuance. There's no one size fits all. So a lot of agility within the organization, I think, has allowed there to be success. And I think we are incentivizing patients and pushing their mindset to build the trust to be able to do get connected digitally, and those that cannot, because of what we're lacking in infrastructure, we're meeting the patients where they are. They're not, being held back, but we're also encouraging them on different innovative ways that they can stay connected through family members engaging, or through social or community-based organizations that can get them connected.
That's super. So I know that we have a question out there. So if I'll need some help to get that. I can't see it in the chat. So if someone is able to get that question, we'll definitely go to it. But I would be super interested to hear one story. One of our panelists have one story how leveraging this tech, you bridge that gap and it helped someone, and what that story was in, but again, we're still in the lightning round, so it's got to be like 60 seconds or less.
I've got one. I was on inpatient service a couple months ago, and we had just recently launched a remote patient management program for infants who were graduating from our NICU and getting to go home for the very first time. And I was talking to this family to advertise this program to them and say, listen, would this be helpful for you? And I just remember this parent who was just so overwhelmed by the care of this newborn, who had a lot of medical complexity and was going to need a lot of medications and supplemental oxygen and tube feeding and things like that. And just the look of relief on her face when we described what this program was and how she could use it to stay connected with her health team. And I think that that's really a motivating factor for a lot of us that work in this digital space.
That's a great story. So as you roll out new tech, right? So you already talked about how we're rolling out new tech and digital, and this is going to get at the heart of the question also. So thank you again to the audience for the audience questions. As you roll out more and more of these capabilities, which are great, how do you ensure that the collaboration, that you have achieved sticks and we don't widen the gap? Because as mentioned a couple of times, in Indiana, especially, although there's other states similar, not everyone has internet connectivity. So what are some best practices that you're doing to make sure you don't actually widen the gap unintentionally?
So I can answer that. Our plans are to create, just like you have like tech hubs, ours will be to create access hubs. We also have a lot of remote clinics that are in areas that, let's use, the best example is during COVID, we had a respiratory clinic that I had started, and the patients that had respiratory symptoms were all going to the respiratory clinic. That meant that all the rest of the clinics were able to be open. We were not compromising care for those patients. But if a patient had symptoms and they were in a rural area and they didn't have connectivity, now what? Well, the patient could drive to the closest clinic to them, and they connected off of the hub that was at that clinic, and they were able to have their telemedicine visit. And so patients didn't have to drive, because sometimes it'll take a patient maybe an hour before they can get to main campus. within 15 or 20 minutes, they were able to get connected, get the care that they wanted without them having that disparity. So there are also programs that are now in our local libraries that teach and educate patients that don't have access, how to connect and how to be online through their libraries.
Super. Max, I know you have a thought on this as well.
Yeah, I think one of the benefits we have in being in healthcare and being the last to evolve with some of these things is that other industries are training our patients on this stuff. So whether that's airline industries, banking, whatever it may be, your local McDonald's, they're getting trained on how to use a kiosk, how to do two-factor authentication. Can you imagine if healthcare rolled out two-factor authentication first and people would be going out of their minds? But, Google did that and everyone else did that. So I think that's very beneficial for us. So really then our responsibility as we roll things out is to bridge that gap between the technology capabilities and the operational desire to connect with the patients. And there's usually a gap there. The technology can do a lot. We just have to figure out what that gap is and help close that gap, whether that's through training or other components there.
Yeah, and I think Max, you and Dr. Bhandari hit on this pretty well, and that is we can always look to other industries, see what they're doing, what they've done, and then replicate that. So we're going to head into what I call, like, we had lightning round just now, but this is one sentence round. So we have a great audience listening today, and some of them are senior like yourselves and have a lot of experience, but a good portion of our audience today are younger in their careers. And so if you found yourself on an elevator with them, so you had basically time enough for one sentence and they were asking you for advice, hey, in general, what do I do? What do I do to connect and collaborate and make sure all voices are heard? What's the one sentence of advice that you would give them? Mohammed, we're starting with you.
Yeah. One sentence would be interconnection. That's what we need.
All right. My friend at CHOP, what would you all do? What would you say?
I would say make sure you focus on mobile first. I think that even if you don't have broadband access, if you develop a strategy that starts with mobility and cell phone, you're going to be better off in the long run.
Love it. Dr. Bhandari.
Data is king. Can't do anything without data.
Love it. You're leading up to our final question, which is one word answer. Max, what about you? What's your one sentence to your younger colleague?
I would say get plugged into all the numerous sources of information out there because things are changing very rapidly. So get plugged in to stay informed and embrace the change that's coming.
So in the last hour, we really talked about connecting the dots on the community collaboration, digital health. You all gave, when I look back at the objectives of what we're trying to achieve, understand the role of digital literacy, identify best practices. We talked some about emerging technologies, how to foster that collaboration. You all covered it brilliantly, but I want to hear one last word before we turn it back over to our host, Rob. What's one word you would use to summarize this entire topic, starting with Max, and we're going to go back the opposite direction?
I'll go with evolutionary.
Evolutionary. Dr. Bhandari.
Transformative.
Mohammed.
Human impact.
Ms. Bell.
Curiosity. Stay curious and keep asking why.
I love this. I personally learned so much. I'm thinking our audience did as well. Rob, thank you so much for having us as part of your program. So I'm going to turn it back over to you.
Okay. Thank you, Ed. What a really fascinating conversation and incredibly uplifting about the progress that folks are making, the introspection and impact that institutions in our area and in Philadelphia are having on their communities. I really want to thank you, Ed, for leading us through this today. Thank our panelists for their time, their expertise. My sense is that we'll have future opportunities to expand on what we're talking about. So thank you again for that. For those of you who joined us today, thank you for participating in this event. Visit our website and watch for details about upcoming webinars. Also in June, we'll be having our face-to-face networking event. As you can see on this picture, last year's event was at the Fountain Square Theater. Look for an event and venue that is equally as exciting. You will also be receiving an email with a link to a webinar archive that will include access to today's webinar as well as previous ones. Please take a look at it, share it with your peers. We welcome your feedback, your suggestions for future events, and thoughts for how we as a local support organization can help you and your organizations transform healthcare. So thank you so much for joining us today. And again, thank you to our panel and our moderator. Have a great day, and we'll see you soon.